Hi.
No, because what's on the 17th grade? Oh, I'm busy that day. It's on a Not enough. Do you know what's the No, I never can section. I never
Good morning, Adam. Okay.
Do you professional scuba diver now? It's like I scuba in the pool.
Yeah, I turned that off too. It's on the side.
I don't think this is, this will help.
So we don't have all. I know. Later group. Yeah, me too. And then we can just be right. Yeah. Almost. We make 3 weeks. I'm not even like,
I forgot.
I have a business on Saturday at Newport.
I was working with
That's the weekend.
I was doing everything together.
1, 2, 3, 4. Okay. I need this.
Turn that one off.
My best friend.
This one on? No, it's
No,
I just shut down this whole thing.
Okay, let's just.
no.
So the microphone's come
1, 2.
on.
Is the
Should
microphone?
be on now.
And let's log him in first before you walk away, please.
Yeah, I'm not going anywhere.
Okay,
I just
thank you.
am telling the microphone.
1, 2, 3, 4. 1, 2,
Should be on.
That one should be on too. The one on your neck should be on.
1, 2, 3, 4. 1, 2.
I just turned it off. It's on now. So like maybe it's only over one on one of the other. I don't know.
1, 2, 3, 4. No, Alan, it's not on.
Is this one working? Talk.
No.
And this one also.
Oh, now you want that one?
Okay, now try that one on.
Now you can hear us all of a sudden?
I heard something though, a few seconds ago.
I just turned it off when it was on. Put it on the counter. I turned it off. Huh?
Checking the batteries.
It's what?
It's battery.
I was checking the batteries.
Yeah, it should be on, so I just turned it
No, it
off.
was on before.
Yeah, because they put it on the counter.
It said everything's booted. The audio should be up, but I don't know how far it goes into Questron. So I'm just booting the Questron right now.
Good morning, guys. Good morning. While Alan is working, I thought we could have a little, because the first part of my presentation, I actually wanted to talk a little bit about my career and my background and so on.
Oh, by the way, he is our chairman, and it's an honor that I could get him today with his very busy schedule.
So this is probably one of the last lectures I'm doing in my life. Being 71 and I'm on my way out. But I wanted to tell you a little bit where this journey started, because you are the key people. You are the key people. I came up at early 1970s. Early 1970s, and you hear I might have a little bit of a funny accent. It's Swinglish, half Swedish, half English. So anyhow, when I came out to start working as a dentist, we, as you know, in the Scandinavian countries, everybody is enrolled in a medical insurance and in a dental insurance. So you come out and work, you take care of the kids. And when you take care of the kids, we had maybe 2 to 3 fillings per year per kid. I had one kid over there and one kid in the other room. I ran them in, and it smelled burnt dentin everywhere. Okay, being 25 plus, it was like, what the heck am I doing? So, with that background, I realized this will not fly.
You want to put mine in
We
there?
had
What is the one we used to use in here?
There's no standard.
We had 2. Actually, we had 1 hygiene training program in the country. 1. Altogether. And I realized there is no way we can handle this, so we really needed to start. Luckily, I had a mother who was into politics. So we started to say, how do we reach the politicians? How do we get the politicians on board of doing this work? So where do we start? Where do you start with kids? You can start, for example, using fluoride toothpaste. When did fluoride toothpaste come?
Fluoride toothpaste?
Yes.
After 6 months?
Which year did it come on the market?
Oh, when did it come out?
It's an American invention. Its name was Crest. It's still on the market. 1955. Yes. And you can see the same trend all over the world. You can go to Australia, you can go to New Zealand, you can go anywhere else. And, oh wow, here it comes. And then maybe I stop a few seconds here.
Which one?
Oh,
Final.
systemic risk factors. Try that one. GP.
Yeah, see if you can afford it. Thanks. Thank you, Alan. So what happened?
It works too.
This whole
Okay.
unit was
This one?
whacked out. The Questron unit.
Can we take down the
Yes.
light a
Yes.
little bit?
Thank you.
So let me back off a little bit then, and saying that I think it's really, you are really the key person.
I'll see you later.
This little story. Oh, now it doesn't work.
Try it.
Alan, wait.
You just did it over there.
Oh, here it comes.
Try again. Try again. Before he leaves. Try again. Try again before he leaves. Make sure it works.
It's not working.
You have to point that way.
It's not working.
We've had problems with that thing. It works slow.
Okay.
Oh, here it works. So this little story. So my lecture is in two parts. My lecture is first a little bit, forget about it, just listen. The second part, I'm going to talk a little bit about systemic. The systemic part of this, of periodontal disease that I'm going to talk about, is, and it's also some pearls and some other stuff. That part, you can choose to listen to me carefully, or you can read the chapters carefully. I have marked those slides with a little star up in the and that star, you can imagine what that means. You will probably get a question from that. This systemic comes back in 435. So I picked out some of the pieces here that I think we need for the first part. The other part is coming later on in the next course. So please pay attention to this, and you don't need to read the textbook in that case. You can save that for the part when you come back next year, I think it is. So anyhow, this little story comes, so we start with a little geography. These are the Scandinavian countries. You see where they are? Up in Alaska. They just had a feet of snow last week. So it's still winter up there. And here's the Arctic Circle, and I was working up here. I was the most northerly working specialist in the world for 25 years. I was competing with Thorin Sigurdsson, who's also been here, Loma Linda, who works in a little city called Akureyri in Iceland. So between the two of us, we were the two most northern working specialists. You see, we have extra letters. A with a dot, A with two dots, and O with two dots. So this is called Luleå. And there's some pictures that you see from that part of the world. It's important for that story to realize that Sweden, for example, is 10 million. I mean, it's nothing. It's like half of Los Angeles for the whole country when we tell this story. So, I started to talk about preventive dental care. And I said we were doing, depending on which age group we are talking about, we were doing 1 or 2 or 3 fillings per year per kid. It did not hold up. That's the dean of the dental school in Gothenburg, and this is the dean of the dental school in Stockholm. And we only have 4 dental schools. So, when you look at it, today with what we did, and I'm coming back to what we did and why you are so important. I get really proud when I see this. Swedish kids today, when they are 19-year-old, they are 76% of the kids don't have a filling. They are white from here to here. Put that in a perspective of 1 or 2 or 3 fillings per year that you saw. And if you look at, for example, over here, number of teeth. Well, in the northern part, when I came out, the 60-year-old patient had 12 teeth when I came out as a dentist. Today, overall in the country, 70-year-old, almost all the teeth. I'm showing this when I talk to dentists sometimes, and the dentist outside is sort of like, oh, that's scary. That's scary. It's almost like, no, that's good. Oh, it's scary. Where's my job going? Where's my money? Where's my Lexus? Where's my house? Where's my other things? So the question is, why did you become a hygienist? Why? Have you asked yourself that? For good income? A nice job? Get married, have kids? Why? Because if you want to work this way, it takes a heck of a lot of efforts. It came to a point that you can see 2009, where the Swedish, Danish, Norwegian, and Finnish government says stop using amalgam. Why? Because when they send out patrons to it, this is how it looked like in the drain system. It's mercury amalgam everywhere in the sewer system. And they said, why do we want to have that? Look in Stockholm, for example. 4,000 pounds per year. This is kilo, is coming out of the drain system during this period. Dentists were doing fillings like crazy. 2009, you could use amalgam, especially if you have people with Down syndromes and other things, because amalgam is a good filling material if you have a high caries activity. But from 2018, they said, no more amalgam at all. So what about US then? Where are we? It's really tricky to find these numbers. This one is coming from a study where they look at a lot of different things, not only about caries, but human beings overall. It's called Hannes. And if you look at that one, this is what you're coming out to. 68% caries. What is that? DMFT. Decayed, missed, filled teeth. Altogether, how is the damage? Per kiddo in US is around 331. In the Scandinavian countries, 0.5. So what is it really who made me proud of this work? When I stopped, I said, we had to start working with the politicians. We really needed to have the politicians on board. All countries have fluoride. And fluoride was not only in toothpaste, it was also rinsing in schools and so on. But how do we get with the dental education? Look here, as I said, with one dental education, we start working with politicians and said we need 20. It's in a country half the size of Los Angeles. So I mean, you can think if you had 20 hygiene training programs in Los Angeles with it. In all over US, 2018 is 74. And there's a dental assistant training program. But these were the key. These are the key people. Because we realized dentists forget about it. Forget about it. We needed the dental hygiene and we needed the dental assistants. And I had to start a couple of these training programs. But we also needed new stuff. So one of the patients, his father up there, came in one day to the clinic and he said, I can do periopix. And you know, periopix in the good old days, they were those round ones that you put when you were cooking. We said, no, we need triangular picks who fits into the area. I can do them in my garage. Okay, so he did. Started to produce them, and you recognize the name. Tandpeter in Swedish, TP, where the name comes from. His son took over. When his son took over, he said, can you help us to design a toothbrush? Yes, we can do that. Can you help us to design some interdental brushes that you have in a clinic? This is today the biggest company in Europe, not in Sweden, in Europe when it comes to this. Where is it coming from? The perio department. Down here is a guy who brushed his teeth. I haven't got $1 from it, but I got a toothbrush in 18 karat gold from the company. That's the only money I got out of it. So education, toothbrush. How do we reach the doctors and the nurses? Yeah, we have to say the dental hygienist and the dentist a little bit, but most of the dental hygienists had to start to go out. We need in those children's centers, we need a hygienist sitting there and meet the moms. They should sit there from the moms are still pregnant until they until the kiddos are 3 years old when they come over to us in dentistry. How do we sell that to the politicians? Sell to the politicians. Kids should have food in school. They shouldn't come with a packet of sandwich and juice and all things. They should be served food in school. And that's good, and that should be a salad bar and so on. That shouldn't be soft drink, that should be milk, that should be water, that should be how do we do that? And how do we get help from the teachers and the teachers union? This was kind of interesting. You can go to the Scandinavian countries, you will never find candy where you pay. Never. It's in a special area. And we were really fighting with this, starting with one of the big, like Target, like Albertson, with these ones, starting with them and start talking to them and saying, guys, do you care about these are the kids? Do you care about them? And always, yeah, of course we do. Of course we do. Okay, put the candy away then. That was one thing. And the other thing, you see, even here, if I take it, it says lördagsgodis. What is it? It's Saturday candy. There's not a Scandinavian kid who don't know what Saturday candy is, because that's the only day in a week you can eat candy, on Saturday. So you see, all this one says Saturday Candy Club, Saturday Sunday, Saturday, how we do it, I mean, around, and take it away from the counters, from it. And it started with something like Costco or something similar to that, where the consumer kind of owns it, and said that you start. If you start, then we can put pressure on the others to do it. Today, it's working everywhere. That's me, how I looked at that time. Looked a little different. So anyhow, so we said, so what are kids doing otherwise? They are reading different kind of cartoons, and not so much at computers and videos and so at that time. They read cartoon. How do we reach Disney, for example? And it actually started here. We were working with these ones, are very popular, the world's strongest bear. How do we get the world's strongest bear? By eating right and brushing his teeth. And this guy who is the owner of it, Rune Andersen, he was like, yes, it's a perfect idea. Let the bear brush his teeth, eat fruit, instead of doing it. And by that, going over to Disney and say, Disney, are you worse? Or will you want to be on board? Do you want to do this? So we were working on all these areas to try to change it to a situation where almost 80% of the 19-year-olds are white from here to here today. When I came here to US 1998, I was offered to be the commissioner of Swedish dentistry, which is the highest position in the country by the government, controlling this. We have been periodontists here at Loma Linda since 1971. And they asked me and said, can you please come over working here? But as you hear, this is very much my passion. Is how do we make people be better? So once more, why did you become a hygienist? If you want to be a hygienist, you have the patient in the chair, but this is a lot of work. It takes a lot of effort to do it. And at a place like Loma Linda, when we talk about mission, this is mission work. This is really mission work. Mission work for me is not to go to Africa. Mission work for me is to go to San Bernardino. That's where the real need is. That's where the real problem is. So as I said, you have 2 chapters here that I'm lecturing around, chapter 8 and chapter 16. If you follow me carefully, you don't need to read the chapters. It's maybe a little star up in the corner. We'll put a little more attention to these ones here. And it's coming back in 435. So let me take a few landmarks here. You remember this: attached gingiva, keratinized gingiva, the gingival margin, mucogingival border, and so on. I think you remember all this. This is not a big issue. Here's a patient who comes to you on 27, have a 10 millimeter pocket. How do you deal with this? What is your treatment? What are you doing? Anybody? If you look at the X-ray, what do you see? Do you see anything who says, wow, maybe I as a hygienist will react here? Anything?
So you would want
Just talk.
an SRP, right? I mean, that's...
Yeah, I mean, you probably want to do SRP. So as you see here, we check this one as we do in many cases, pulp test. So pulp seems to be okay. But do you see any problem with this 10 millimeter pocket? Or just, yes, SRP. Whoops. Part of the training is to start using your brain. Really. And start using your brain is that you start looking at what you see. And what do you see? You see an intra-bony defect who goes all the way down here. You've had plenty of lectures in scaling root planning and so on. Can you get a curette down here? No. So how would you get down and clean here? So if you clean only up there and you leave the shit down here, then you probably get an abscess. Okay? So use your brain, look at it, and try to see what you can do. Sure enough, I got this picture from one of the dentists outside, and you can see that they was scale and root planning 3 times during 1 year. And you can actually see how long the scaler went. And they left that. Okay. So, here's a patient when it comes to me. I said, Tord, can you take this? It's a referral. And I said, maybe now it's too late. Because it became an abscess, it blew up, and you can see how they've been scaling. And look, I said, yeah, I can treat that. I can treat it by taking it out. But I can't do anything with it. And I can put it back with a little composite, and then you can get it back to your clinic. But this is what happened. What is the reason? Almost every single tooth you're going to treat have concavities. Almost everyone. And we teach and say, oh, this is a root. Go down with the instrument and scrape a little bit on it. No. Use your brain. Look at the picture up there, up here. These are a few of the teeth you're dealing with. They have cavities. All of them. They have concavities, all of them. And you know what's worse? This is an Australian guy, Robert Bowers. He was looking. It's even deeper on the inside. So when you start to have cases, and I say, you really have a problem. Because now you have concavities on the inside and you have concavities on the outside of it. So not only the concavities, then you have other anomalies. So what do we call this? Huh? It's coming on next picture. But what I want to say, here you see once more. I say concavities everywhere. And not only that, I could show you studies that is almost impossible to clean in the top of the furcation. In there. I used to say when I lecture, hygienist is a much more difficult job than being a dentist. To clean these teeth is extremely, extremely difficult. And to clean these ones, you maybe need to have not only hand instruments, you maybe need to have an ultrasonic instrument, or you maybe need even a little rotational diamond or something. But you can't clean this in furcation involvements. That's what you meet. So this is called enamel projections. Why are they important? Yeah, because when you have dentin, you remember you have dentin, you have cementum, you have the sharpest fibers. But on enamel, you only have small hemidesmosomes, called small rubber cups who suck on to the enamel. And of course, if you have these ones, it's a weak spot. So look at it and see where is the concavities, where is the enamel projections. Don't learn the numbers. That's nothing you need to have. Look at the picture. Look at a beautiful picture. The tooth with periodontal disease. You see concavities? Yep. Enamel projection? Yep. But maybe most important, how do the calculus look like? This is your everyday 8 to 5 work. Yeah. Does it look easy to go down and scrape that off? And you see another thing, and that is, why is the calculus coming in these small islands here and there? I have no answer, but I've seen it for 40 years. Enamel pearls, I hardly haven't seen almost anything, but it's in the textbook, so at least we have to talk about it. You mainly find it in the molar areas, enamel pearls. It's a little star up there, so there may be something there that you should maybe look in the text. Let me say a few words about where if I asked the periodontist outside and I said, how much of your work, what are you doing every day today? I get this answer approximately, 40-50% implants. I mean, in other words, take the teeth out and screw the patient. That's one thing. And then maybe 20-25% what I'm going to talk about, aesthetic dentistry, to cover recessions. Okay, 50 plus 25 or 75%. That means that the dentist outside is maybe spending, you know how much a GP is spending per year with period? Insurance claim? 3%. 3%. Here sits the people with our soldiers, our things, 3%. So anyhow, it's a lot of things who can contribute to recessions. Biotype, for example, and you can imagine that yourself. If you have a thick gums, you can brush on it much more to get a recession. If you have a thin one, it will probably recede much quicker. Luckily, the thick is much more prevalent. I don't need to spend, you can read yourself here. Of course, the more you brush, the more you pick, and the more you do on the gingiva, the more it will probably recede. And there may be other things like a frenulum, like other things contributing. Read that yourself. So how common is recessions? Al-Bandar? Where is he now? Do you know that? Al-Bandar?
Right now, I'm not sure.
No, I think he's over in Boston. Anyway, he was over in Norway for a period, but I think he went back to the US again. But this is a study from the East Coast, somewhere. People are 30 years old, recessions 3%, like 1 in 5 are showing more than 3 millimeter recession somewhere. If I move over to Scandinavian countries, fairly similar number. And because Swedes maybe brush a little more, in average, it's maybe even more recessions. So here comes a kiddo to you. And this one is 8 years old. And the mom is of course concerned about the way it looked like here. So what are you doing? Yeah, nothing, I hope at least work on the oral hygiene part of it. Maybe change the oral hygiene technique, maybe. Take a toothbrush in the hand and see how you're scrubbing the teeth. Or maybe you can maybe roll the gums up in that area and work on the technique a little bit. Because if you look at here, you can definitely see there is some plaque here. Can we agree on that?
Yes.
This patient I saw for a number of years, and this is how he presented himself when he was 23. Look here, no keratinized gingiva, this much. There are studies out here. Growing kids are presented with increased weight of keratinized gingiva. Good to know. You can tell the mom and say, if you take it easy and clean it carefully here, it will probably end up in a fairly normal session later on because the keratinized gingiva is increasing in width during age. So let me say a few words, 4 or 5 slides about what I said that periodontists maybe 20 to 30% are doing. Periodontal plastic surgery, mucogingival surgery. It's many names for the same, but I can say that you more or less agreed there in the mid-1990s that the name to use is periodontal plastic surgery. The definition from the workshop you find on that slide. But you should know, because you will meet every single day almost in the clinic patients who sit there and they say, oh, I have a little recession here. What can be done with that one? It's disturbing because it's on the front tooth. What can be done with that one? And you can either say, I know a little about it, or you can say, I don't know anything about it, so I need to send it to the dentist. Worst, the dentist often unable. That's another issue. But what I think you should know is the Miller classification, which is used very common everywhere. And as you see, the Miller classification 1 is when the recession stays within the keratinized gingiva. 1 can be covered almost 100% in all situations. 2, it passes the mucogingival border, can be covered in almost 100% in all situations. Here comes the problem, where you have to look if you see the patient in the chair. You have to start looking at the interproximal area. If you look at the X-ray, you'll start seeing, oh, you lost some mesial bone, lost some distal bone. The papillae start to disappear here. Now we start to have a problem as periodontists. we can say, oh, we can cover maybe 60%, 50%, we can cover, but it's really tricky to get a really perfect result. And here, when it's a lot of loss, and a lot of these patients you will see, you go in, you look at the x-ray and say, oh, mesial bone is gone, this bone is gone, and the patient wishes that we can cover it all. Forget about it. You can't. There's nobody showing that we are going to get the gums. Because you know the term biologic width. Biologic width means more or less 3 millimeter. When it exceeds, when the soft tissues exceed 3 millimeter, it's not much we can do. Sorry. So at least you have a feeling for that. If you have younger people with recessions, either passing by the mucogenital, but the papilla is okay and the bone is okay, we can do wonder. We can cover them almost 100% in all situations. And it's not only us, it's a lot of studies showing that too. Miller class 1, class 2. Now we start losing back here. 3, we can probably cover it up something like this. You can cut 3 millimeter from biologic vein, maybe something like that, but not more. And 4, forget about it. So some surgical, when I came out, and I was in your age, the periodontal plastic surgery we learned was to put on, take out the pellet, took out and sewed on something on it, and it looked like this. And you can imagine why I wasn't so thrilled about that. I mean, yes, it's really nice that we get a little more attached gingiva, maybe it holds off when the patient brush. But you know, that wasn't why the patient came to me. The patient came because I didn't like what it looked like. And if I'm doing this, the patient going to say it's even uglier than it was before. So this was before 1985. Take out a piece of gums from the pellet, sew it on, like this one. When you see we have made the bed, here's the periosteum. We try to split it so we keep the periosteum from the bone. So suture it on as much as we can, and a couple of years afterwards they also shrink. So it was actually after 1985 when we started to see patients coming in like this that we said, let's do it in another way. Let me see what I have here. Yes. Maybe we can make tunnels, lift up, and stick it instead of put it on top, stick it under. Like tunnelation in it. But you can imagine that's a rather big piece to take out in the palate. And where do we take it? Up here. What do you have back there? An artery, a vein. How many times have I cut that artery vein? A number of times. You cut the artery, it's like in the wall. Is the patient dying? No, but you have to, it's a little scary when you see it first time. So you see here, stick it in under, suture it, 16 months later. And this picture, if you concentrate on it a little bit, you can see. I talked to the patient and said, you know, I can take out more, so we maybe need to do it here too, later. But the patient said, this was my main problem. So he was happy with that and said, I can live with these ones over here. So he said, no, I don't want to do anything more. So that's 16 months after that, what's called a tunnel procedure. So if you don't want to take out connective tissue, they start to come on the market. Freeze-dried material, freeze-dried skin, if I put it like that. And you see now I can get out a much bigger piece of it. Just for your knowledge. And here is a case after 2 years. If you don't cover alloderm, it can stick up under the gums. You will not succeed. And here you see what we were talking about this with biotypes. It's a typical, very thin, paper thin biotype of gums. And if we go in and cover that one, after 3 years, it looked like that. We have a little loss of the papillae, so we can't get full 100%. You see it? I wonder if I took in. No. But it's also patients who come in and say, you know, I have too much gums, I want it to fix, I have a gummy smile. And what we are looking at is the front teeth, how long they are, and as you see the lateral should be a little shorter here and a little shorter there. So how do we work with a gum here? Take a patient like that, came a few years ago. Her main concern was that one. So of course you have to tell her, I can't take away the yellow spots with surgery. But we can try to work a little bit on the gums here. The two there that you see, the lateral incisor, is almost higher than the other one there. These ones should be on the same level. So there is some stuff, but mainly we can move all these. And all the way here, the gum is a little bit too high. So we can open it up, take away a little of the gum, open it up, and biologic width have to move the bone up a little bit to create this 3 millimeter that we want to have here. After 3 days suture, I use a lot of Gore-Tex sutures. They hold up really well, the same as you have in your rain jacket. Polytetrafluoroethylene. But if you look at after 3 days how it looked like, after a week it's time to take out the sutures. 3 months we have to maybe do some veneers here to get that one. And I think I put in a picture on 3 years. It's not ideal. It's really tricky when you have the restorative, the borderline with the porcelain here. You can see the small, what's called Jan Egelberg blood, small blood vessels up there. It's a little subclinical inflammation up there. If you've never seen a princess in your life, here's one. I spent 8 years in Saudi, 2 were only up there. So working in a hospital private for the royal family, and here's one of those patients who look like this. And if you have all the money in the world, you can say, nah, I maybe don't want to look like that. So the same stuff here, you see we can come a long way. What I want you to pay attention to is that it's not only the crown lengthening, but now we learn to do this with the veneers, ear veneers or crowns. But look at the contact area. Look at the contact area. See some of the commercials on TV when they are talking about these teeth in a day, whatever they are called and so on. And the way to kind of give an illusion of having papillae is there is to have a long contact area, because you know from the point where you have the contact area up to the bone, it can almost never exceed 3 millimeters. If it does, you get a blank trial. I think I only put in one of these because we have I had a number of these patients. To just give you an example, we do a periodontal plastic surgery. We do also this kind of crown lengthening. So what about perio now? We start tilting over to systemic factors here. This guy here is actually one of the world's most famous periodontists. It's Stefan Rimmer. So we were residents together. And when I take photos and have Stefan say, please don't brush your teeth. This is how he looked like. 0 days, 2 days, 4 days, 5 days. You need to memorize this a little bit because you have the patient who come to you, sit in the chair and said, oh, I didn't brush my teeth this morning. No, you didn't brush your teeth the last 5 days. But you maybe can't say that to the patient. But at least you kind of get a feeling for it. The other issue that I didn't put in any slide to talk about is that you lift up a boat. What is this? If you have a sailing boat down in Newport, you have to clean it under once a week. Because otherwise you will get what we call the pellicle, the glycoproteins under it. And when you get the glycoproteins that you have there, you start to get a bunch of bacteria coming up here on it. End of 1970s, we had a teamwork with SeaWorld, San Diego. We were asking, why is it the dolphins seem to swim faster than any other fish? You know why? Because they have an alcohol called delmopinol on the surface. They never get this. Almost all other fish get it, but not dolphins. They have like an oily film. So we took that delmopinol, gave it to the hygiene students, and they did not get any plaque at all. And then you say, why isn't everyone using delmopinol? Because the next step is you do it on animals. The animal study, and sadly, the animal started to show a tendency of cancer. But you can actually find, I would say, inactive delmopinol on the market today. Because the problem is, it gets inactivated in days. So you heard that name, delmopinol, and it comes from these studies that you find on the market. You need to know a little bit of these bacteria. Look how beautiful AA is. Look how ugly PG is. And the third red complex bacteria, the Forsythus. Oops, there's a star again. And I'm not going into this detail. I don't really want you to know the yellow, the pink, and so on, but at least you should have a feeling that when we talk about so much about the red complex bacteria, actually AA doesn't belong there. It's not there. It's a separate group. We have right now a couple of master projects where we try to put ozone into olive oil and using it. And actually the ozone in olive oil is equal or better than chlorhexidine. And that is, we're testing a few of these bacteria. So it's also interesting to see. But from your perspective, red complex, you definitely should know it. AA, you definitely should know it, what it is. And I also think you somewhere in the background should know the main types of white blood cells. It's so much discussions about white blood cells. For example, the B lymphocytes, what are they doing? Producing, they develop into plasma cells, and plasma cells have antibodies. The monocyte develop into the big eaters, the macrophage, for the phagocytosis. The lymphocytes, NK cells, is the main big producers of cytokines. What is cytokines? Inflammatory mediators. Inflammatory mediators. They're kind of a communication system between cells. But when they communicate with cells, usually that cell they communicate with starts spitting out a lot of substances who creates inflammation. I'm coming back to this a little in the end. I think you should know in big pictures of that one. So for me, periodontal disease. I showed you a picture of the concavities. This is the other picture that I have in my mind, and they followed me for 40 years. This is periodontal disease. If you go through the hygiene training and you don't have concavities and you have what periodontal disease is, you will have a problem. So what do you see?
Not the same.
This is what you see. You see a wall. It is a wall down there. Yeah. And what do you have in a wall? You have an enemy and you have a protector. And now you can understand a lot of the studies who talks about maintenance, for example, and surgery. Because let's say I take a knife now, shoop, and I take that away. What did I do? I took away all the defense. And what do you think will happen? The other patient will have an even more rapid periodontal disease. We had a research project a number of years ago with hygienists involved and said, let's do periosurgery on one group, periosurgery on the other group. Our hygienist take care of the maintenance, and the other one we send back to the referring dentist. The ones we send back to the referring dentist in 2 years lost 2 millimeter bone. Why? Because we took away all the defense. So you put a knife in a patient. The message to the periodontist and the dentist is, you put a knife in the patient, you take a lot of responsibility. So please understand, this is probably the most severe periodontal disease I've seen in my life. It's almost nothing. And by the way, here's the typical of these patients I'm talking about 1960s and 70s. And you can imagine how much amalgam were used to try to do this if we try to work with these patient groups. The other picture, yeah.
The picture before, the worst one that you see, did you just remove the teeth?
Say that once more.
That one, the worst one that you've ever seen, did you just remove the teeth?
Yeah, it's not much you can do there. It's not much you can do. I can talk a lot about this one because a lot of periodontal disease. What is the most important for me to treat periodontal disease? Do you know what that is?
Preventing.
Mobility. Mobility. That's why it's so important when you look at your exam and you're doing it, because if there is a 6, 7, 8 millimeter pocket and it's rock solid, I can say, I can probably treat that one fairly well. If there's a 6, 7, 8 millimeter pocket and the tooth spot like this, I can say, take it out. There's probably nothing I can do with it. Yeah.
Sorry to interrupt you. They usually have 10 minutes break from 9 to 9:10.
No. Can I continue? Or you want to go out there? It's really hot in here, so maybe it's good if you take a break for a few minutes. Okay, let's do that. Can you actually put on the air conditioning?
They get a brain freeze. Yeah.
I'll let
Just see if we can put on the air conditioning.
Really sorry to interrupt.
No.
Okay, whoever was late, somebody was late for attendance. One person came late and didn't sign.
Tell her to start.
Oh, my shoes are tied.
It's funny that this one doesn't work.
Thank you very much, doctor. It was so interesting. I hope that they get the most out of the lecture.
That's it.
So actually it seems that everybody has signed.
I think they're there, all of them, aren't they?
Yeah, it seems that everybody has signed. But somebody came late and didn't sign that.
No, I think everyone's on.
Yeah. Actually.
I have a question for you.
Sure.
So, after I graduate, I want to do veneers and crown lengthening, like the gingivectomy. But I've had a lot of people tell me I shouldn't do it. So I'm like, I don't know.
Why shouldn't you do it?
Well, because they're saying like I shouldn't remove tissue if I don't, like, I don't know. People are just trying to deter me away from it, but I really want to do it.
Yeah.
You think it's okay?
Yeah.
And like, I know you showed the surgery, but I know a lot of the dentists now use the laser.
No.
No? Is
No.
that bad? The laser?
I tell you one, and that is, I mean, if it's one who is super long experience what they are doing, it's okay. Most scenarios, no.
No.
And in the specialist training, we don't use laser for that at all, nothing. And I tell you what, and that is, let's say that you have 10 cases. One of them have ultra thin bones, because if you have very thin gums, you often have very thin bone too. Okay, what do the laser create? A lot of heat.
Oh.
So
So
now
it
you
could
go
kill
in with the
the-
laser, and you don't know when you come in with this one how thin the bone. And if the bone is paper thin, when you have there, you maybe wanted to remove 0.5 millimeter bone, but actually 3 millimeter bone went.
I didn't realize it removes bone too.
Yes.
That's scary.
9 out of 10 times. Yeah, because if you have the gum line here, and you have the bone here,
Uh-huh.
your body creates a biologic will. This is your biologic will.
Uh-huh.
And it may be 2 in some, it may be 4 in some, but it's unique for your body, biologic will. So if I now take that one down there, you know what will happen in the bone down here? If you're lucky. Most studies shows you take the gum down there, the gum will grow. Again, because you have the bone here.
Yeah.
In 85% of the cases, the bone is the thicker type. But now we say you have a very thin type. Okay, so now you take the gums down here, and you have a really thin type here. And you have no control where the bone is going to go.
Yeah.
Yeah, so the laser creates a lot of heat. So in 8 out of 10, you're okay. But 2 out of 10, you instead of losing 1 millimeter, you lost 3 millimeter bone. And then what you place down actually will receive.
So the crown lengthening,
So
not.
with these, and me working with a lot of high-end VIPs and so on with this one, I would never use a laser for doing that. If
Okay.
they start talking about a laser doing that, I would say, oh, no. I
Okay.
think I would go. But I mean, you have people who are really good at this, and if you want to this, I mean, I know a few people around.
Okay.
If you want the highest end, this Peter Nordland down in La Jolla. People flying in, and people is here as a part. He's helping me.
What is his name? I'll look it up.
Nordland, Peter. La Jolla. And you call him. If you call him, you can say just say you spoke to Tord about it.
Okay. All right, I see him here.
Yeah.
So the type of surgery that you showed, is that something that can be done under the local anesthesia?
yes.
Okay. Okay.
It's not.
Okay.
It's the same anesthesia as doing a filling. It's the same anesthesia as doing everything else. It look a little more when you have it there, but you don't
Okay.
know that when you sit in the chair.
Okay. Yeah, because
No,
I mean,
so you're going to have it for the rest of your life. So you need to have
Yeah.
somebody with a lot of experience. You need
Yeah.
somebody who really know what they're doing.
I've seen a lot of horror cases with
No.
veneers too. Okay. Well, that's good to know because the dentist that I found that I liked his work, I think he uses the laser. And then that's another thing too. So if they do the gingivectomy, does the tissue heals and makes the normal like free gingival margin again? Does it recontour itself?
It builds up all of it, but I can show you. I was actually talking to the endo residents on Thursday, I think last week, when we went through research on it, and 3 out of 4 of the research bounce back, depending on that you don't touch the bone.
Okay.
Yeah, so there's only a few studies that really saying that you take down the gums, you also have to take down the bone because you want the biologic will.
Okay.
And that's only people who really understand this can do it. So that's why, I mean, how easy would it be for me to work on this high-end piece? To say, I use a laser.
Yeah.
Yeah. And
Yeah.
then 2 out of 10 was screwed up.
Yeah.
Yeah, I'll probably get a one-way ticket out of it.
Yeah. Well, and one of the other dentists told me that I have a hyperactive muscle here.
Forget about
Yeah.
that. Forget about that. Okay. Can we start again?
Yes.
First picture I show you, cavity. Second picture I showed to you was wall. The third picture I showed to you is this one. When I mean, I'd say that where is the border between what we are doing here and here? It's amazing to me. I mean, in many times I look at dentistry a little bit like a bicycle repair shop. We so often forget this with biology. I was talking to one person yesterday, and talking about biology, we're talking about biology, we talk about it. And when you talk about infections, and you talk about periodontal disease, this is what it is. 2 full hands of infection. And I always used to tell the patient, if you have 2 full hands of infection of an arm, would you go to the doctor? Yeah. Directly. That morning. But when we talk about periodontal disease, it's like, oops, who cares? It bleeds a little sometimes and so on. But of course that will have a tremendous impact. And during these 40 years I've been working, it really started to shape. It started a train, and it started here, a research train. It started actually in Finland with a guy called Mattila working in the ER, in the emergency room. And he said, I have all these patients coming in with heart infarct and strokes, but they look so bad in the mouth. And he wrote an article and said, can it be that it's this big infections that we are talking about who has an impact? And people start looking at it. And if you look at it then from the research, you can see that you have, you can find PG, I can pull these ones up. You can find PG, Porphyromonas gingivalis, inside epithelial cells. You start to see plaques. Many times when you take a regular panel X-ray, you can actually see these plaques on the neck on it. So, here, last time I looked it up, it's more than 400 articles talking about periodontal disease and heart disease. But here is where it started in the end of 1980s. Around 1990 or something like that, I was asked to go to the Scandinavian Heart Association's conference and talk about these early studies. It wasn't mine, it was other people doing it. I'd probably never been so nervous in my life. Who am I? A dentist standing in front of a cardiologist and talk about cardiology and infections. But I tell you, I got the biggest applause that day. And not only that, the main news on TV that night was this. Watch out with your teeth, your gums, your infections. It can have a tremendous impact on your heart. This one comes from Stefan Reinhardt, is a very good friend of mine, to try to put some of this research together. And you can say, when you take that research and you see how much bone loss and periodontal disease you have the odds ratio. It means how more likely will you find periodontal disease. So you have like 20-30%. 5 to 8% more likely that patient who is showing you look at the X-ray and say, oh, it's not a bone loss. By the way, do you have any problems with your heart? Do you take some heart medications or do you do something? There seems to be some kind of correlation here. The other one, when I grew up, maybe 2% of the population had diabetes. Today, I think we have passed 9% of the population. If you go to Middle East, probably 15% of the population. Junk food in combination with genetical predisposition for it. But as you see a little star up there, I think you should know a little bit of what this is about. It's very common. The Scandinavian countries is the part of the world where you find most type 1 in the world. Why? Because type 1 is probably the virus infection in the background. Genetic predisposition and a virus. So you find much more of type 1 in that part of the world. But here you find mainly type 2. Put a little bit of attention and look at it when you come home. In normal, this square is a cell. It's kind of funny form of the cell. It's this one figure comes out of a textbook. So the cell needs energy. So what does it do when it needs energy? It puts up a TV antenna. And then in the blood who's circulating or whatever liquid is circulating, it says, can I have glucose somewhere? And the glucose comes, it comes, and the TV antenna put it in the cell. That's an easy way of explaining how the cell goes normally. So what's happening then in a type 1 diabetes? I need energy, I send out my antenna, but there is no insulin. There is no production of insulin anywhere because these beta cells that you find in pancreas, the virus, we have antibody. They killed it. There is no. But even maybe more interesting is when you look at the type 2. It's a cell. We need energy. But when you have a bad lifestyle and so on when it comes to this, then the antenna is blocked. So it doesn't matter how much insulin is passing here. It's blocked. What's good about it with type 2 is that you have a window. You have a window of some a few months, others a few years, where you can open the TV antenna again and it starts working. Go down in weight, change your lifestyle, do these things, the antennas start to work again and we can make this work. But as I said, it's a short window. After that, when these one close permanently, then even these patients need special treatment with insulin and so on. So read that. Sudden onset, autoimmune, probably some virus in the background, destroy the beta cells. What is ketosis and ketoacidosis? You know, you can have a diabetes patient, you can almost feel they smell almost like acetone on them. So what is that? That is that when the body can't use carbohydrate, if you need energy and you can use carbohydrate, what do you use? Then you have to use lipids or you have to use proteins. And when you break down lipids and proteins, you get toxic products who is toxic to other cells, who is this ketosis. In type 2, you see there is lower number of ketosis, but even there are studies showing that type 2 even have a stronger genetic predisposition than type 1. Of course, how you live depends on it, and you can put this from American studies, and I don't know how much you can put into it genetically. Maybe it's more the lifestyle in it, but please be aware that there is a difference. And you see, you can go into, this one is a number of years, but you can go into some 60 years plus, and you're up to 25% diabetes. Will you meet these patients? Yes, every day, almost. There's a little star on that one too. You should know that around 126 milligram per deciliter or 7 millimole per liter is the borderline. We talk about the pre-diabetes and we talk about diabetes. And they're doing it with a, as you know, with a stick and a testing of the blood glucose level, and they're measuring it. And the other one is this hemoglobin A1C, 6-7%, and so on. I'm not going to go into it. I don't think we have time to go in to look at that. But what's happening here is when the glucose is traveling around the blood, what is in the blood? What is mainly the component in blood? Red blood cells. What do the red blood cells have to pick up the oxygen? The hemoglobin. Sadly, the glucose is attaching to the hemoglobin. And when it attaches, it can't get loose. It stays there until that cell dies, and that takes around a month for it to do. So we call this reaction AGE, glucosylated hemoglobin. And you test it with this HbA1c test. I think this is another thing that is important, and that is when you look at your HbA1c and you look at the glucose and you remember that around 126 milligram per deciliter is the normal value. But let's say you come up to 8 here. I'm going to show you a couple of cases here soon. We start talking in average about more than 200 in blood glucose. These patients are well educated. They sit in your chair. You ask them and they say, what's your HbA1c? Oh, it's around 8. Okay. That means you're probably rather off when it comes to blood glucose levels. So there is a clear correlation between those two. We talked about that. The most common way in US of being blind is diabetes. The most common reason to be blind in the US is diabetes. So it starts to be small blood vessels break, and when they break, it can be severe bleeding. So retinopathy, after 10 years of diabetes, 50% of the patients, after 15 years, 100% of patients have eye problems. Where do they have problems more? Fingers, toes, ask them. Don't be surprised. I have a number of patients who tell me, I can't have sex anymore. No, because it doesn't work. Everywhere where you have small blood vessels, diabetes work. So even on that side, I mean, it's a little sensitive as a dentist and so on. So how is your sex life? You have to joke about it a little bit, but I mean, it's you will find that everywhere where you have small blood vessels, you have some kind of reaction. This is interesting. So, how do we treat the diabetes patients? We have to treat them fairly aggressive. With aggressive, this study has come from New England Journal of Medical. 1,400 patients. You follow them for 10 years. What do? You give them, this is type 1 diabetes. So you really check them with insulin all the time. Check up by the doctor, check up by the nurse, check up with what they eat, what they drink, what they exercise, and doing all these. And look here, reduction of complications. Reduction 76, NERD 60%. Who cares? But that, you care as a hygienist. 3 times more situations with severe hypoglycemia. So when the patient comes to you and they say, I'm really under strict control for my diabetes, you as a hygienist, me as a dentist, who said, oh, oh, now I really have to watch this a little careful. Because, as I'm going to tell you in a few seconds, if you have a hyper, too much glucose in the blood, a hyperglycemia, not a big deal. If you have a hypo, these patients can go into coma or seizures very quickly. So it's not the hyper, it's the hypo who is important. Study clearly showing that. Or this is a type 2 with even more, 5,000 patients, type 2, 20 years. They give them tablets. Some of them give them insulin. The same increase hypoglycemia. So they have medical reason. From medical perspective, they have really good results. But for us, they come and they're going to have a severe SRP, or they're going to have a tooth extracted. They're going to have like that. So I'm scared. I didn't eat my breakfast this morning. Or maybe I'm nervous. I'm stressed. And you put nervous stress and on top of that, really the blood glucose level goes down. So watch out with these ones. Other things that you see in diabetes: dry mouth, burning syndromes from tongue, from cheeks, from other things. Less saliva. If you have less saliva in the mouth, it's running like an engine without oil. You start to get candida infections and, of course, other infections. We already talked about this, that when it has, especially on the small blood vessels, it has a tremendous effect on the small blood vessels. So treating, now first is the risk. Diabetes is a risk for periodontitis, a number of studies. Diabetes subjects with periodontal complication is more severe. So it's not only you have periodontitis, you also have more severe periodontal disease. You're more susceptible to infections. How much? This study, around 3 times more susceptible. This time, 2.6. And this time, depending on which group you are talking about here, an odds ratio between 3 and 11. You know what the 11 is? And we live close to it. Pima Indians, Arizona, 60-70% of them have diabetes. A very strong genetic predisposition in that area. And there is a number of articles coming from Arizona, from that area, and especially that for Taylor. Have done a number of studies down there. Improve perio and diabetes, the metabolic control. Chemotaxis, what is that? Here comes the picture with the battlefield. What is the chemotaxis? What is that?
That's how they travel
It's
to
the
the district.
troop transportation way. It's to get the troops in, to attract them to the battlefield. And now the troops comes in, and now they have to start fighting. And most of them fight by try to include bacteria and break them down. So diabetes is shown that they have less troop transportation capacities, they have less phagocytosis, they have hyper-responsive monocytes and macrophages. Let me come back to that in a very, very end, if I have a chance to it. Because most of the periodontitis today is actually showing it's maybe not a bad immune system. It's in most situations it's actually an immune system who reacts too much. We talked about that. And we also a little bit talked about this, how important it is as you as clinicians really keep track of that. Where is the blood glucose level? Most of the patients, you have a meter in the clinic, ask the patients to bring it with them when they have it or whatever. And please be aware that we are mainly talking about the hypoglycemia. If the patient, I think it's on the next slide here. Yes. Look at this. This is hypoglycemia. Look at the symptoms. And compare them to that. Not a big difference, is it? When you sit as a clinician, you're going to say, wow, is this a hyper or a hypo? And what do I do? And do I remember? And I say, forget about it. Treat everyone as a hypo, because that's the one who quickly can go in to if they are hyper up there, you give them a glass of juice, or you give them a sugar and so on. So what? Nothing will really happen, because it's probably in that situation more the stress, more the situation you have around them. Calm them down, talk to them, and stop the treatment. Give them a glass of juice, or give them something else, and stop it. But treat it as a hypoglycemia. And you see what I'm saying? It's like for dentists, maybe pre-sedation in advance, maybe treat them in the morning, maybe try to find the situations where the patients feel better about it. Okay, let me show you a couple of cases. 24-year-old, she comes to me and said, I'm going to get married in 2 months. Can you please do something so I look nice for my marriage, my wedding? Very easy, isn't it? No? Let me give you another. This girl, now you see, we talk about this with coloring the teeth and so on. She had not brushed her teeth for at least 4 or 5 days. Can we agree on that? Can you see? Yeah. 12-year-old, type 1 diabetes, 1 year. And I was lucky to get that picture, because this is how she looked like when she turned up with me later. Little different. What's happened from that to that? She comes in, she has greasy hair, she has fever, she doesn't look good at all. So I more or less told her and said, go home and get your toilet bag. I'm going to send you to the infection clinic, and I'm going to admit you for it. And she more like, you're going to start treating now. You have fever, you're bad, this one is what you have. And I mean, you can see the pus coming up, the pockets a little bit everywhere here, on a patient who is 23 years old. So into the ward, take a forceps. 4 months after that. So it ended up with only a few teeth we could keep. These ones are many, many years old, so I apologize for the very bad or removable denture. But she was treated, without going into detail, she was actually treated with IV antibiotics and extractions at that time. And this is, okay, and this is how she looked like 14 years after the treatment. And I also managed to get a picture of her. So a few more teeth are gone, and little caries, and dry mouths, problem with it. So please, diabetes patients have problems. They have problems. Many times they don't want to admit it. They have problems. They have problems in the, as I said, what about your sex life? What about your family? What about your life overall? What about what you're eating and drinking? What about, I mean, treat these patients very carefully, because they need help. What do you see? This girl comes in, referred for this front area, with a referral said, cancer? It doesn't look like a cancer to me. It looked like a regular abscess, infection. But what is this? What is that? I stick a mirror in her hand and I said, her name is Virpi. I said, Virpi, I'm going to take you on a guided tour. So I stopped talking to her. And he was silent. Same diabetes patient. Very silent, didn't say much, didn't want to argue. And you see, I'm the kind of person who talks too much, not too little. Yeah, so we were talking a little bit when she left. And we agreed to take those 2 teeth out. We agreed to maybe try to do a little Maryland bridge, composite retained bridge or something to do with. And of course, gangling group planning, oral hygiene instruction, and all the other stuff in here. The day after, they called me from internal medicine and they said, what are you doing? I said, what am I doing? I didn't do anything. I talked to her. She's sitting here and she's crying like crazy. So I said, no, I just took her on a guided tour, take her around. And then the doctor, the female internal medicine doctor said, you know, I've seen her for more than 10 years. And she started coming now and saying that her father has molested her for a number of years. And her response to that is eating and drinking. What do you call it? Give me the word. Anorexia. Anorectic reaction. And not only that, she is, when you get this, you are throwing up regularly. So I uploaded all this from this little infection. These kind of patients have problems. Not saying you get molested by diabetes, but in this case, look at the caries on the backside, on the lingual. Now, oral hygiene instruction, talk to Bond, try to talk to her. This is after 6 months, and this is how she looked like 16 years later. She got a bridge in the lower, which is maybe not the most beautiful I've seen, but at least it seemed to work. But look at the gums. Look at the gums. You can almost see in these patients. The gums is the mirror of your body. You can see here that she has very thin epithelium. You can see that these gums are very different than you see in many other situations. Be detectives. This one comes 12-year-old with an abscess here. And of course, then the dentist can tell you and say, oh, go in and do SRP. If you go and do SRP, what are you doing? You take out the root cementum. If you take out the root cementum, you can never get the sharpest fibers back. So, oops, you screwed up that tooth for a 12-year-old. Okay, so instead, is it a piece of popcorn? Is it something in there who can explain it? Maybe antibiotics, rinse out the pocket, keep it the way it is, and test it, of course. And when you test it, pulp test is negative because an abscess makes the tooth. So a lot of dentists, when I asked them, they said, oh, we do an endo. No, don't do an endo. Don't. Look at it, and you see after 3 weeks, the pulp testing comes back. It's only rinsed out. It only put the patient on antibiotics. After 3 months, everything is back. Could have done it so wrong. Diabetes patients, once more, susceptible to infections. Puberty, a little star again. I don't think I want to say much more about it than if you take 2 patients, the one who is in puberty reacts stronger to plaque. because of these hormones. So you need plaque, and when you have plaque, you get a stronger reaction, period. Pregnancy. Same. Now it's not progesterone, now we're talking about estrogen, and it gets worse around the second month, and it's the peak at around 8 months of it. So when we started with this treatment, in Sweden, we convinced the government that every pregnant woman should have 100% dental care free. And it has been since, because during that pregnancy, you are much more susceptible to these kind of infections, peaking at around 8 months. If you get this kind of, look at the difference, actually. It's the same oral hygiene almost. Look at the gums. Look here, the pregnant 8 months. See how the gums are reacting, you see? When you look at it, and here she comes back, postpartum here. Yeah, she brushed a little better, but you can definitely see how the gums are reacting. Very different. And this pregnancy, what is it called? Pyogenic granuloma. If they are smaller, they can disappear by themselves. If they are bigger, no, we have the knife to take them out. But you know, these kind of patients, they come, they are in the 8 months, and you say, oh, I want to remove that one. You know what they say? Can't we wait, doctor? I don't want to have the surgery, I don't want to have the anesthesia, I don't want to do this because I care about my kid, I care about that. So it's often that discussion. It's like, no, it's better to wait and see. And in many of those situations, it actually disappears. If they are big like this, it will not disappear by itself. It's a very funny experience. You know, a few months ago I had prostate cancer, so I went through this proton therapy plus Lupron, which is anti-progesterone. So I have had for the last 4 months exactly this. So I used to say, I know exactly how old a woman is. Like 10 times per day, you have this kind of reaction. And it comes in flashes. I mean, otherwise, it's not much to say about this group. What about this? This lady is a nurse. She comes to me. She's actually an instruction nurse. And she said, oh, my gums start to work. Start to grow like this one. And you look, here's that one, here's that one. Does it look normal? No. I had to take a biopsy. Was I scared? Yeah. Because I didn't know how much of a bleeding I would get up here. But this is an infiltrate of leukemia. Leukemic infiltrate in the gums. Do you need to know it? I think you need to know it looks different. Send it away. It looks different. And you have a number of these cases, and I can show you. I started as a hospital dentist and worked for a number of years. And a lot of these younger kids with different kinds of leukemia, different kinds of these ones, we had them down in the clinic once per day. Why? Because they cannot eat and drink, they cannot brush. Because you give them these kind of medications, they look like a meatball. And what the doctor is looking, he looked in here and said, yeah, I seem to have the right dosage. Because when it starts to desquamate, like you see here, then the doctor knows, yes, I'm on the right dosage. If it doesn't do it, then the doctor says, no, I need to increase it. Can you understand how important it is for these patients to come to the dental clinic every day? But they can't brush themselves. They hardly can eat with it. But that also means that we increase the survival up to 90% or more of these ones here. But they really need help from us. We can jump that. I also want to show you a few pictures of this with hyperplasia. I mean, there's a number of medications. You can look at it yourself. There's a number of medications, but mainly if we focus on this one and look at the difference. If you look at this, Dilantin, it increases both the epithelium and the connective tissue. And you can see that. See what a beautiful picture. And of course you can understand that if you have this situation, you need help of a dentist or a hygienist. And in many situations we have to by surgery remove it. A few other pictures. Some of them are disabled, handicapped, like this girl. Look at how severe it looked like. This was the first patient in Sweden who got both a new heart and a new lung at the same time. They took out the whole package and put it in. And this one here then, of course, give them calcium channel blockers, but they give them cyclosporine. And I think I've done surgery on these guys at least 4 or 5 times because it actually grows up, so it almost grows over the teeth. So the problem, because he doesn't care much about the way it looked like, he cared more, can I chew on the teeth? So we have to go in and adjust here and there for that. But this is cyclosporine. These ones you will meet. And when I come out and I see the hygienist, and the hygienist said, oh, I have a 6-7 millimeter pocket. I scaled 3 times and nothing is happening. Because look at the gums. You see, we can take this area. It doesn't look inflamed. It doesn't look like, but the 6-7 millimeter pocket will never disappear because it's an hyperplasia. So even you can scale this 100 times if you want to, and it will never disappear because these hyperplasia look different with the calcium channel blockers. It's another kind of hyperplasia. We can jump that. Once more, I just want to show you, this is not normal. This is a girl who is just graduating as a psychologist. When she graduated, she comes into the clinic and she said, can I go on holiday? And I said, no, that's not a good. She actually got a gift and going to Canary Islands from her parents. And I said, that's not a good idea. So I took a mirror, once more took a finger, off comes the whole epithelium from it. So these kind of patients is autoimmune antibodies between the epithelial cells. And the only way you can treat this one is for life with corticosteroids. Do we need a hygienist? Yeah. Do we need it regularly? Yeah. But you see how we can get from this situation, for example, to this situation in a year. From the tongue to that tongue within a year. With oral hygiene, with working with the doctors with corticosteroids. But these patients need corticosteroids, all of them. Let me say a few words because the time is out. You go to Vietnam War and so on. Maybe 90% of the people you see in the front line in the Vietnam War is showing signs of necrotizing gingivitis. And what you do is you look just on the top of the papillae. So you look at it and often you don't even need to look. You can go into the room and you can say, yes, necrotizing gingivitis, because they often smell with it. So it's pain, ulcerations, bleeding, and malodor. There's the picture. There's some more, so it's not only the papillae. It can be out in the mucosa. I take this one last and then I give up. So what is this? This is actually another royal who had been in Las Vegas for months in high life. So she comes to the clinic and says, I have pain. So what is that? The patient sits down in your chair. What is it? It's open bone. It's open bone. The gums is gone. But what I was looking at is mainly this. Because if a patient comes with this and have red bands around the teeth, I start thinking, oh, can this be HIV, AIDS? Look at some I had over the years. We had in Saudi, for example, we had close to 100 HIV patients at the hospital. It attacks your T cells, start with an infection, patient got fever, then it normalizes after a few days and it disappears kind of for a long time, which makes the patient feel like, oh, it was nothing. And then slowly by slowly it starts to take down the CD4 cells until a level of less than 200, where we call it AIDS. And these AIDS patients, in the end, they get from tumors to, you see yourself. It's all right. I wonder if I put in some in end of life. Yeah. I mean, look at some of them. Message, they get everything because the immune system is really down. So here the immune system is. The last 2 or 3 slides is another group that are probably the one I've seen most of in the world. It's called Papillon-Lefèvre syndrome. Look at the patients, 12 years old, keratinization in hand and feet. These are the top of the iceberg. If you want to talk about a patient who get periodontitis quicker than anything else, this is the group. They're all married to the cousin, so it's running in the family, which is very typical in Middle East. That you marry your cousin, you marry within the tribe. But look at the case that it is. And my part of it is, we found another group in Tallahassee, the same. This time it was black people within the family. Is that periodontal disease is very often not an underreaction of the immune system. It's an overreaction. And from all these cases, what we can show is that it's like somebody has a bad temper. I put on somebody and they say, that's how the immune system in many of these patients react. Papillon-Lefèvre patients, a lot of these. So the research in perio is actually tilting very much from, oh, they are very susceptible to infections, to no, they have an overreaction to inflammation. They have a very strong inflammatory reaction. Antibodies. Thank you guys for listening.
Thank you, Dr.
Oh, you heard it. Thank you.
How do I get a Debbie to come set up everything for me?
Oh.
That's easy. Just talk to him.
Yeah.
Okay.
Do you have something now? Sorry.
Okay, thank you. You have both?
This one.
No, they gave it to you. Did you give it to them?
So what?
That thumb drive.
Hold on.
Someone gave it to you, and they said they found it and was giving it to you.
Oh, they give it to me.
Open it
put it
up
there.
and see. Let me see. We can plug it in and see whose it is.
Yeah, they said they found it and was giving it to him.
Okay.
Yeah, they said it's for you. Okay.
When we get out of here, do we get out of here with the laser certification, or we need to go and get that
You'll
somewhere
have
else?
a type of laser certificate, but it is not. Yeah, it's not the full-blown
But
lasers.
will
You'll
we-
have experience
Will
with
we
it.
be able to
You can
work?
use it, yes.